Reaching the unreached, where are we at present? Where we do stand and what we need to do. Basically, these days, reaching the unreached has become a word in every sector. Whether it is you know about smile train, whether it's a blindness or whether it's a poverty alleviation, any cause, any social cause, there the word is used, reaching the unreached. So reaching the unreached is basically a dynamic, evolving process which always requires innovation to reach the last man, the last beneficiary standing in the last row. And the needs of the unreached are always central to the innovation which we want to implement over here. To reach the unreached, a system-wide coordinated approach combining national and global evidence and the capability of the local level adaptation is required. Means we have to work at the national level, we have to work at the global level, and of course the local level is mandatory. And in this, the three priority action areas are that we have to strengthen the primary health. Regarding the blindness, we have to strengthen the primary healthcare system so that enhanced inclusivity and equity of the participants is there. We have to empower the communities and individuals to foster health promotion and participation. And we have to address the socio-economic determinants to tackle barriers in the health service access. So these are three things that we have to involve communities, we have to do health system and health services, and of course the political will is always required. And these basically three things they require, they have to be integrated into 5 transformative domains. That is, we need to have political commitments and the multi-stakeholder engagements. Everyone has to be involved. And of course, the data-driven decision-making. We have to take the feedback, we have to collect the data, and only then we have to decide upon the policies. And then, of course, health service evolution. We have to integrate the techniques as well as we have to provide the latest technology so that the results are not bad. And we have to have special innovative approaches. That is basically, as I told you, the dynamic process, and we have to have new innovations into this system also. So this is basically five system approach. So for community engagements to contribute to effective change, efforts need to go into defining the goals and the purpose, why we are engaged into it, and working out the most effective strategies to realize our goals. Then, up to what extent the policymakers and providers are willing to share power and implement change so that we get the desired results. And of course, we have to have the trust in the community so that we can penetrate and we can provide the care to the last one. As far as this blindness is concerned, we have been using all the data. We have been, but the latest one is RAP data, rapid data by Dr. Praveen Vasisht at AIIMS, which was published in 2022. And for that, the blindness is less than 3/60 in the best eye. They have created another category, that is pinhole blind, means best corrected again less than 3/60. And there is a category of functional low vision also. So at present situation in the world is there, that is over 6 billion, suppose this is the situation, that in the population of 7 billion, 6 billion are users of the mobile, and still the 4 billion of the population in the globe is still unreached by this connectivity. But what about access to the health? What about access to the eye care facilities when providers are so less and demand is so high? And again, the uniformity of the healthcare which is not distributed. So we have to think for that also, that we have to provide access to the healthcare. And as far as blindness is concerned, it is a significant public health problem which is global problem and disproportionately large prevalence in the low and middle income countries. So again, as far as the scenario of the India is concerned, it is a public health problem, and around 5 million people are blind and 70 million are visually impaired, and of course 0.24 million people, the patients are children. By literature, if you go, India is known as the blind capital of the world due to its high prevalence of the avoidable blindness, especially the elderly population, which is almost non-productive, but children population which is involved, which is going to be the productive population. More than 1/4 of the person aged 50 years and above are visually impaired. So India and China, they account for 49% of the world's total burden of the blindness and vision impairment, and as far as their population is concerned, that is 37%. But they are contributing around 50% to the blindness. So we need to have improvement in Indian scenario of the blindness so that the global burden of the eye disease is reduced. So IAPB says that India possesses the maximum number of the people with total vision loss and the blindness, and 80 to 90% of this blindness can be prevented by simple medical attention and awareness. The two things which is being emphasized always and everywhere, that is cataract and refractive errors, they top the cause of the blindness causes. And again, survey says that the rural areas are more affected, and because of the higher population and which is difficult to reach areas. Rural and tribal areas, the lack of the ophthalmologist or proper infrastructure again, delays the diagnosis. So this is basically the area of the crux. And these are the major causes by RAB survey, that is cataract, opacities, and of course these days surgical complications is contributing to lot. And glaucoma, 5.5%. The proportion of the blindness and visual impairment is such that due to avoidable causes, the visual impairment is 97% itself. So in the ongoing process, India has made significant strides towards the elimination of this avoidable blindness, and as for the latest data of the RAB, it has reduced up to a significant extent. So what are the factors which are affecting the eye care? Everything is affected, but one thing is most important, that is demand-based factor. They are contributing a lot. That is, जरूरत ही नहीं लगी जी, no felt need, lack of a person, हमारे साथ कोई जाने वाला नहीं था, या सर्जरी में डर लगता है. So they say that 80% of the people who are seeking attention, the medical, they need medical care as far as the blindness is concerned. These factors work over there. So we have to, allay these fears. We have to go into the society, and we have to do the cost-effective, care for them. So another concept is case finding and treatment initiation cost concept, which is new these days. Case finding means starting from the case to the treatment initiation. How much is the cost incurring on that particular patient, and inclusive of everything, that is spectacles, corrective surgeries, everything. And even this concept involves engaging the population in the risk diagnosis with visual impairment and converting the diagnosis to the treatment also. On one side, as far as the urban population is concerned, access is not the problem. In the rural, remote areas, access is still the problem. And so most of the factor, cost effectiveness in the India is the cost of the case finding and treatment initiation. In the last person standing in the row. So we have to have direct our strategies on this particular aspect so that the blindness, the prevalence of the blindness is decreased, and in the region as well as in the world. Pivots of the approach in the community is door-to-door screening, And another concept is school screening. We want to, diagnose the blindness, the refractive errors in the children, so that our productive population is not affected. So, keeping this thing in mind, these days, the vision center has become the nodal point, slightly shifting the role of the camps. Earlier, used to the camps once in a month, twice in 2 months, 3 months, एक कैंप होता था गांव में, एंड देयर सर्जरी जो मिली वो कर दिया. नेक्स्ट टाइम जब तक कैंप लगता था कुछ पेशेंट्स ब्लाइंड हो जाते थे. बट दीज डेज गवर्नमेंट, NGOs, दे आर डेवलपिंग द कंसेप्ट ऑफ द विजन सेंटर. So that person, optometrist or assistant, is available over there round the month, round the year, round the day. In the community, he can diagnose the patient, he can, diagnose the disease, and surgery is advisable, or the blindness is cured. So there comes the role of the teleophthalmology. How he is doing? He is sitting at the remote place, but he is giving the diagnosis or correcting the disease with the help of the teleophthalmology. So these days, again, the screening camps, only screening camps, not surgical camps, and vision centers, they are becoming the most effective cost strategies for identifying and encouraging individuals to undertake the corrective eye surgeries services, so that cost-effective service is provided. What are the areas of emphasis? It is required, we have to require the eye banking and corneal transplantation on the other front. Through vision centers, we are putting emphasis on the community and school health services. And of course, with this, we have to improve our surgical side effects also. So refractive error screen is the must, or becoming a point of the emphasis. So we have to see the role of the teleophthalmology also. Teleophthalmology is again becoming affordable and feasible tool for providing eye care delivery, especially in the rural, tribal and remote areas. And of course, in the whole of the country where the end user is to be benefited. It is a workable model in ophthalmology practice, as well as saving the substantial cost to the community and to the provider also. And it is beneficial in so many things, that is screening, consulting, counseling, prioritizing the patients, optimizing the medications, supervisions also, follow-ups also, education also, emergency services also. So it is particularly useful in remote areas or rural areas where specialists are not available and where screening and evaluation is a problem. And so many even companies are helping out. Thank you.
Thank you, Dr. Inder, for highlighting the role of community ophthalmology to cater the eye care services to the population where there is a little need for those services. I think it is a collective, it should be collective efforts of the government, then NGOs and eye care providers. Thank you very much.
Thank you, sir.